All right, let me share my screen here. Okay, and open the slideshow. All right. Hopefully this is recording this round. This is literally round 3. I tried recording this at my office a few days ago. I just tried recording this at home and then realized I didn't hit record after talking for 30 minutes. So I'm going to do this once again. And so tonight I'm going to be doing an overview of platelet-rich plasma, or PRP, and we're going to be talking about what is it and what is the evidence. So background about myself, I'm board certified in sports medicine, family medicine, and osteopathic manipulative medicine. I'm the owner, CEO, and medical director of Motions Medicine Sports Medicine. I've been practicing in the Dallas-Fort Worth Metroplex for a little over a decade. My practice specializes in sports medicine, non-operative orthopedics, regenerative orthopedic medicine that we'll be talking about tonight, osteopathic manipulative medicine, and concussion management. And I'm a team physician for the XFL San Antonio Brahmas and for USA Wrestling, USA Judo, and the US Olympic and Paralympic Committee. So my experience with regenerative orthopedic medicine, ROM, you're going to see this acronym a lot. I've been doing prolotherapy since 2010. I've been doing PRP a little over a decade. I've been doing microfragmented adipose tissue, which is one of the stem cell treatments, since 2017, and then bone marrow aspirate since 2020. And then extracorporeal shockwave treatment I've been doing since 2021. Today we're going to be talking about the what's, the hows, and the who's. So the what's are, what is it? What's the science? What's the evidence? What's the process? The hows are, how's the recovery? How's it compared to surgery? How do I schedule? And the who's a good candidate? So what is it? So let's start by talking about regenerative orthopedic medicine first. So the analogy I always talk about is fixing the chronic pothole in the road. So when we sustain an injury, think about a road that sustains a pothole. So initially, somebody will call the city, and then the city will get attention and it'll say, ooh, okay, I need to send some healing factors, some city workers out there. And so if the workers go out there and they have the right supplies, they do a good job, and we allow that road to set before we start driving on again, typically normal road, no issues. Very often, either the workers don't do a good job, but probably more commonly, we start driving on that road a little bit too premature, and then we kind of start ripping that pothole right back up again. And the city is only going to send its healing factors out there so many times before it just says, you know what, I'm not going to lay down any kind of healthy tissue. I'm going to lay down some scar, disordered collagen tissue, and you're just going to have to deal with it. I'm not saying my city workers, my healing factors down that street anymore. And so when we need to get the body to be able to heal itself, then we need to kind of show itself that it needs to kind of go back over to this area that's forgotten how to kind of get there. And we do that by either using growth factors or growth factor stimulants to get that process going. So more specifically, PRP is autologous blood. It's spun down in a centrifuge to separate the red blood cells from plasma. And then we extract the platelet level, which has the growth factors on there, from the plasma. And classically, we talk about leukocyte rich, or we talk about leukocyte poor that has the white cell layer, and we'll talk about why that's important. So breaking it down into these 3 layers, okay, we have the red blood cells, which are heavier on the bottom. We have that buffy coat with the white blood cells and platelets kind of in the middle. And then we have that plasma layer on the top that's very water-based and has some proteins in there. Activating agents, and I don't use an activating agent, but some PRPs require that is a part of the process, and so that helps with degranulation of platelets to release the growth factors and precipitates the clotting process to confine the secretion of molecules at the chosen site. And so calcium chloride and thrombin are some of those. So I will use thrombin when I'm making platelet releaseate, which is a different form of a healing thing to get those factors to be able to come off a little bit sooner. Otherwise, I typically inject it into tissue that's already going to be using a natural activating agent. And we know that growth factors are, they play a critical role in the healing process. And so all these growth factors are part of what makes PRP work the way it does. And we know that, regenerative orthopedic medicine is a growth factor driven therapy. And so it targets the inflammatory phase of the healing cascade. And so what I always have to tell my patients is inflammation is not a bad guy. It's part of our body's natural healing cascade. And so if we allow natural inflammation to occur, things are going to heal better and quicker. And so with this, it triggers this response that leads to more stem cell migration, and it helps transition that inflammatory phase to proliferation and remodeling, which is what we need for cellular repair. I always like to talk about the osteopathic approach because I use these 4 principles of osteopathic medicine with every single patient encounter I have. And I always say this is not unique to DOs. It's just something that should be integrated within osteopathic education as far as this is how we should be treating our patients. And notably, in the talking about the sports medicine and regenerative medicine kind of field, the second one on the top right, the body is capable of self-regulation, self-healing, and health maintenance. I love this one because it really summates so much of what I'm trying to kind of do. I'll say that we all have to walk a path of wellness to get ourselves better. And so that should be a nice straight line. Some people get deviated off of it and we have to kind of redirect them on it. And some people have a little bit of a boulder in that path. And we need to see, is there something that we can do to help remove that boulder so that people can keep kind of walking? And that's where regenerative medicine can sometimes be that boulder remover to be able to keep them walking forward. As far as musculoskeletal uses, so the common ways that we're going to be using it is into joints or intra-articular. And classically, the research has dictated that we use leukocyte pore for that because of its anti-inflammatory effects. And then when we're doing kind of peritendinous ligamentous or intratendinous ligamentous or extra-articular outside the joint, that's where we classically use a leukocyte-rich PRP, which tends to encourage that good aspect of inflammation and healing. As far as using it for nerve, not a lot of people in the country using PRP for nerve. I'd actually say I'm one of the few in the country that are notably using it effectively for nerve. And I will use it for intraneural treatment as far as injecting into the nerve. I will do it around nerves perineurally, or more specifically, I'll do a hydrodissection, which is where we're injecting an amount of fluid that helps break up adhesions and restores the natural architecture of the compressed nerve. And sometimes I'm doing it neurally, where we kind of inject it subcutaneously, also known as the Lifkoff technique after Dr. Lifkoff in Germany, who kind of pioneered that, classically with a dextrose solution, but I've been using it neurally with PRP or platelet releasate. And then non-musculoskeletal uses, there's some growing kind of ones, but some of the more common ones are burn treatments, wound treatments, hair restoration, and for certain dermatologic conditions. A lot of people are getting these PRP facials and they're swearing by those. So why do we care? Why do we care? So nobody likes pain. So whether it be shoulder pain, back pain, hand and wrist pain, knee pain, foot and ankle, neck, hip, nobody likes pain. But what do we do for pain? What are options for treating chronic nerve and or musculoskeletal pain? So we know there's pain medicines like over-the-counters like Tylenol, NSAIDs. We know there's prescription things like opiates. We know there's an opiate crisis that we have. We're trying to get people off or try to avoid prescribing those. We know there's consequences of taking too much of these over-the-counters like Tylenol, NSAIDs. We know there's sequelae of that. And so is there other things that we can do? So bracing, taping, again, those might be some good transient kind of things, but we know that long-term that can actually lead to further problems. It can lead to destabilization of the joint because we're not activating the proprioceptive fibers that need to be kind of stabilizing the joint. Exercise is definitely one of the best things that we can be doing. And exercise and motion is the best medicine. That's why I prescribe, some sort of exercise or home exercise program for every single patient that comes to see me, making sure that they're doing something to be active. Because ultimately, I can do some neat things to show their body how to heal itself, but it's up to them to be able to maintain that and work on prevention. So after we're done rehabbing, we need a prehab. And along that, so that's where I partner with a lot of physical therapists in the area, make sure everybody gets at least some sort of home exercise program. And my athletic trainer is also able to do rehabilitation out of our practice. Steroid and viscosupplementation injections, and I'm going to talk a little bit more about steroid, but visco, for that aren't familiar, or hyaluronic acid injections are an effective, painful, or effective treatment for pain. Have gone a little bit out of favor as far as insurance covering it in the last few years, but I still think it's effective. I don't think it's not regenerative, it's not degenerative, it's more of a stabilizing kind of thing. And so it can help with pain, it can help with lubrication, it can help with, it can be a little bit of block inflammation a little bit, but it tends to kind of kick it down the road, doesn't tend to fix too much. Osteopathic manipulative treatment, OMT. So I'm a DO that utilizes a lot of this. And this is me teaching over in Germany. They wanted to see how we did osteopathic manipulative treatment and osteopathic sports medicine over there. And I find that people that respond really well to manipulation, or maybe they've seen a chiropractor or a physical therapist, and when they respond to a manual therapy, but then it keeps kind of coming back, it's a roller coaster. It's better, it's worse, it's better, it's worse. Those are the kind of people that respond really well to these regenerative treatments, because often it's ligamentous instability and it's musculotendinous kind of instability that is also just kind of leading to these chronic kind of issues. So if we can stabilize those things up, then they get better. Surgery is an option, and it shouldn't be an option, but it shouldn't be our first option for most things. Now, if they're in a trauma bay and their bone is sticking out and it's fractured in a million places, yeah, surgery is going to be the best option. But if they're presenting to you in an outpatient kind of elective setting, very often there should be a lot of things that should be entertained before surgery is that option. So what about? Is there anything else? And that's what we're going to be talking about, regenerative orthopedic medicine. And we're going to be talking more specifically about this liquid gold PRP that we have right over here. So talking about steroids. So steroids, again, haven't even been around 100 years. And so we've been utilizing them for the longest time. They were, again, it was the greatest thing since sliced bread. I mean, it helped people, and I still use them. They can help acutely kind of get people out of pain, can calm down some inflammation. And if we just use a steroid once or something, that's probably not the end of the world. But I say, it's like if I inject a steroid in somebody's knee and they get better for like 3 years, and then I need to repeat it again, it's probably not doing any big long-term damage. But if it's only like 3 weeks or 3 months, and then we just keep throwing steroid in there time and time again, we know that's causing degeneration of the cartilage or the soft tissue that we're injecting into. And so it definitely increases the chance that they're going to need some sort of surgical procedure sooner than later. And so if we can avoid steroids for a lot of different things, we need to be able to do that. But what can we use? Well, PRP, really, I mean, it's like in the last 20 years, I would say, that's where PRP's really kind of gained a lot of momentum and excitement. So I'd say the hype and the media frenzy came about in the last 20 years. The research has really caught up in the last decade or so. But there were athletes like Kobe and Tiger and Roger Federer that were really had a lot of notoriety and were really talking it up. Hines Ward had it right before the Super Bowl, and he is now the head coach of the San Antonio Brahmas that I'm working with. So I'm actually really looking forward to having a sit down and being able to talk about his PRP experience with him. So this treatment spectrum is something I showed my patients, and I'm going to be coming back to this a few different times during this presentation. And on the left, I show things that are degenerative, towards the middle, stabilizing, and towards the right, regenerative. And I have the regenerative orthopedic medicine, the ROM things featured here on the right. And I have extracorporeal shockwave treatment and prolotherapy, and then platelet-rich plasma and stem cell. And that's my microfragmented adipose tissue, as well as bone marrow treatments that we do. And I also talk about them as in-season versus out-of-season treatments. And I'll talk about that a little bit later when we're talking about rehab, because that helps me kind of make decisions with the patient. So in regards to talking about what the evidence is, and really as far as talking about evidence of PRP, we could have a lecture or multiple lectures on just specific subtopics within this. But overall, much more positive than negative. And so, in treating things like the rotator cuff tendinopathy, treating things like elbow epicondylopathy, tennis elbow, lateral epicondylitis, gluteal tendinopathy, hamstring tendinopathy, patellar tendinopathy. It shows mostly positive, but mixed results on the Achilles. I really think that has to do with the approach. Very often I find that Achilles tendinopathy is not a manifestation of just the tendon, but the paratendon also that leads to tenosynovitis. And so not only do I just do PRP intratendinously, but I will also hydrodissect the paratendon simultaneously, and I tend to have a very good history and results with doing that. Low back pain, again, is such a there's such a diversity of things that can be causing low back pain. But, a lot of times it might be discogenic, it might be facetogenic, it might be spondylitic, it might be degenerative disc. There's so many different kind of things that it could be. But the big recurring kind of theme is we see atrophy of our supportive musculature, notably our rector spinae muscles and those tiny little stabilizing muscles like the multifidi. We see the tendon units kind of getting worn out. We see ligamentous laxity leading to instability. And so when we do this, when we do like a regenerative treatment, I'm stabilizing all those weak structures and renewing the integrity of them. And so maybe I'm not fixing that degenerative disc, but I'm stabilizing around it so that you don't feel it. And so that's where we see the excellent results as far as doing this. And things like arthritis and knee arthritis has definitely kind of hogged up most of the research. We've seen some excellent things as far as randomized controlled trials using things like prolotherapy and platelet-rich plasma, where we've seen a little bit more mix, but I feel like the research is catching up in regards to using micronized fat as well as bone marrow. Notably, when we talk about arthritis between about grade 0 to 4, so grade 0 is nothing, totally normal knee, grade 4 is bone on bone. And when we see it's in that grade 1 to 2 kind of phase, those people tend to do the best with the PRP historically with the evidence. When we talk about the foot and the plantar fascia, again, excellent results with that. As far as in treating acute injuries, acute injuries, notably if it's in the muscle, we actually see some better evidence of using something like platelet-poor plasma. But I would say Shockwave actually has one of the few things where I've seen of the regenerative treatments that works fantastic with acute injuries. So if somebody just comes in with a recent ankle or knee sprain or shoulder capsule sprain, I treat it with Shockwave and I get them better so much quicker. And so it's a less invasive, less costly kind of treatment. And again, it works so well that tends to be most of what I typically do for these acute injuries. In talking about PRP research, so there's good and bad and future kind of things. So some of the good is, there's been a lot of meta-analyses on randomized control studies that have shown positive results for knee osteoarthritis as well as lateral epicondylosis, so tennis elbow. And overall, just diffusely across it, it's shown that, PRP has a very safe profile, even compared to things like steroids and surgery and everything like that, a very safe profile. So again, very low risk, high reward when we do it. The bad part is that there's low quality studies, there's inconsistencies and no standardization. And so again, it's like, it's just like if you look at OMT as far as research. With PRP, there's not really a standardized PRP as much. There's different kits that people use. There's also variable amounts of what platelet concentrations are. Again, normal platelet concentration can be between 150 to 450,000 on an individual, saying that it's within normal limits. So if I take 150,000 and I concentrate it 3 times, as opposed to concentrating 450,000 3 times, we can see what that end product is. And typically we need to concentrate PRP at least 5 to 6 times for most individuals for it to be efficacious for whatever that we need to be able to do. So if I only concentrate 150,000 by 1.4 times, technically that's defined as PRP because it's greater than its baseline amount. But is it efficacious PRP? So I think we need to kind of maybe have a specific kind of standard where we say PRP is getting a platelet count of X amount or of a specific, this many times concentrated before we could say it's legitimate, safe to use PRP or effective to use PRP. And so that's the future. We need to, get some research recommendations, get more standardization, get, all of our kits that are out there that are being, promoted by the FDA as cleared, that they are also, getting consistent kind of results. So that's where the future needs to go with this. As far as the process, so we were talking about our pothole in the road. So how are you going to rebuild your road? And so if we're doing something like prolotherapy, I say we're using the needle to kind of break up that pothole. And then the solution itself, which is typically a dextrose-based solution, is putting that call into the city, telling the city, okay, we need to send your healing factors back out there. And so that's how they're going to get there to repair that road. With PRP, we're taking the blood, we're spitting it down, getting the concentrated growth factor, injecting that into the area. So essentially, we're putting the workers directly there, and then they can take a look around and say, ooh, we're going to call into the city and get some backup to signal some additional cells to be able to come out there and help with the healing. When we do our stem cell procedures, either bone marrow or the MFAT, essentially, we're digging the hole up, but we're putting the workers directly there. They have all the supplies they need to be able to fill it in. They have the mayor there supervising them, and they can call in this city and the next city over to make sure that they just have more of a robust plethora of growth factors to be able to repair it. So that's how I kind of show it as far as from a potency standpoint. Once again, talking about that PRP process. So we start with the venipuncture, which after a single centrifugation, we see it into those 3 layers. We separate out that red blood cell layer, and then we do another centrifugation so that we can isolate the platelet-rich plasma from the platelet-poor plasma. And then for those that need it, there's an activation agent that is used, or the tissue itself is used as the activating agent. As far as the recovery, So again, another thing that we don't have a great consensus on. There's been some research out there, and I really try to abide by what the research has kind of shown. And so I really stick with, there's been some good stuff that came out of the Mayo Clinic at Ohio State. And so I've really kind of looked at those protocols and modified them accordingly over the years to make sure that I'm in compliance and giving our body the best chance it can to heal itself. When we do Prolo and Shockwave, I talk about that as my in-season treatment because I do the procedure, you take it easy for 3 to 4 days, and then you ease back into activity. When I do my orthobiologic procedures, so PRP, BMA, MFAT, we typically have 72 hours of partial weight bearing and are using a sling, 2 weeks of taking it easy, and then easing back into activity and progressing through therapy over the next 4 to 10 weeks. And it may be up to about 3 months before full recovery is noted, but usually by the 6-week mark, we're able to kind of see where most people need to kind of be. As far as contraindications, is this for everybody? And the answer is no. So if they have active cancer, I would definitely want to be active, or past history of cancer. I might want to be consulting with their oncologist. I don't want to be seeding anything from one area of the body to another. If they have certain blood diseases or anything like that, want to make sure that we're being careful with that. And if they're on anticoagulation therapy like Coumadin or warfarin, we got to be careful with that also, just because we might, it might lead to less efficacious or inefficacious platelet-rich plasma, and so maybe that's not going to be the best treatment for us to be able to do. And so being able to kind of discuss that, and whoever is kind of prescribing that, can we take a little bit of a holiday from that, discontinue them for a few days and then restart them a few days after, just to make sure that we give their body the best chance it can to heal itself. So how does this compare to surgery? And so I've taken a few different major surgeries, very common ones, and put them like head to head with what we're doing with regenerative medicine. So if we look at rotator cuff surgery, so rotator cuff surgery on average costs about 26 grand. So based on your insurance, you might be, fronting 1,000 to 7,000 out of your pocket. And then you're in a sling for like up to 6 weeks. It might be 4 to 10 months of pain and recovery, and 4 to 12 months typically that you're looking at from a rehabilitation standpoint to be able to get back to 100%. Whereas if we're doing PRP, we're talking about a fraction of that costs. It's done in a clinic, you're home the same day, maybe in a sling, not 4 to 6 weeks, but 3 days. And then, 2 weeks to easing back into activity and getting pain relief. And so again, when you put those side by side, it seems like a, pretty, again, low risk, high reward kind of thing to be doing something like PRP. When we're talking about something like a knee replacement, so again, very expensive, average $57,000. So if you have a 20% co-insurance and a $7,200 deductible, you're looking at paying about $7,200 out of pocket for that. You need to stay in the hospital after. It might be, again, up to a year before you're, back to your 100%. And that's saying you ever get there. And then again, with this is, done in the clinic, home the same day, again, low risk, high reward, and very low cost also, all things considered. So if we can get to the same or better outcome, why not try something like this before you kind of go down that more difficult road? Let's talk about a spinal fusion, because again, these happen a lot. And I should have been a spine fusion because my God, look at this, 110K. So based on your insurance, you might be responsible for a quarter of that. That's a lot of money. You're staying in the hospital for up to almost a week. Baseline pain and function might not happen until 3 months out. 73% likelihood of recurrence of pain within 3 months. 73%, not very good odds there. As opposed to doing something like regenerative medicine, again, give it a shot. Again, literally, no, slight pun intended there. It's so low risk, so high reward. Why wouldn't somebody want to consider this before they do something a lot more invasive on themselves? So let's talk about some candidacy. So I use my family as some examples of different people here. So this is Sue. This is my mom. She's a little bit older than 55 now, but she is a recreational golfer. And she was diagnosed with knee arthritis. And, over the years, she's had some transient relief with steroid injections, viscosupplementation injections, physical therapy. But she, wants to avoid a knee replacement, keep playing golf and playing with her grandkids. So we come back to that treatment spectrum that we were talking about before. And so looking at the regenerative treatments, in this case, I would talk to her about possibly doing PRP or stem cell, depending on, the gradation of her arthritis. And she had Kellgren-Lawrence grade 2. So kind of in that, mild to moderate kind of. And so we did PRP on her, and she did fantastic with that. This is my daughter, Hannah, who's now 16, but she was dancing back when she was 14, and she has an acute onset of heel pain, diagnosed with Achilles tendonitis. She was working with the school athletic trainer, but she wants to be able to keep dancing without pain, and she didn't want to miss out on her upcoming competition. So when we kind of take a look at our spectrum, this is one of those in-season kind of situations. So I wouldn't recommend PRP for something like this. I'd recommend Shockwave or Prolo. And again, notably with the high schoolers, you mentioned doing something with a needle and their eyes get all big, a little tear kind of comes out. Shockwave, it's non-invasive, no needles. It's a much quicker kind of procedure. And so that's what we end up doing for most of my high school kids that kind of come in with an acute injury. For Mike, this is my dad. He's a 68-year-old recreational softball player, acute on chronic shoulder pain. He was diagnosed with a near full thickness tear of his rotator cuff. He had a steroid done into the subacromial space that didn't help. He's unable to do physical therapy secondary to pain, but he does want to avoid surgery. He wants to return to playing softball and being able to play with his grandkids. And so in this case, we would think about possibly PRP or stem cell. And a lot of it has to do with the size of the tear. So if we have a complete tear with it's completely retracted back, then I don't think I'm going to be able to do a magic regenerative treatment to be able to get everything to be able to bridge itself back across. Maybe I could help stabilize the pain from it, so we could give it a try, but as far as being able to get the tissue to repair itself, probably forgone. But a lot of times we see that there's a full thickness, but maybe it's kind of held together at certain parts. And so there's just a gap and we need a scaffold across it. And so if it's a pretty big gap, that's where I think about doing like the microfragmented adipose tissue stem cell procedure, because fat is a great natural scaffold that kind of comes across there. But if it's a little bit of a tear, we can usually fill that in with PRP. And if it's a little bit bigger, but not quite enough to need the fat scaffold, sometimes we'll make a fibrin scaffold by taking a little bit of extra blood, activating it to create a fibrin scaffold, and then injecting that across the area first, and then coating the PRP on top of that. So many things that we can do with this to be able to get people better. And then Dan, and I'm, again, 6 years older than this now. So recreational weightlifter and works with his hands, progressive elbow pain over the past few months, diagnosed with tennis elbow, attempted to rehab, but pain was recalcitrant, and wants to be able to live without apprehension in the gym, work without pain, and play with my kids without worrying of worsening my condition. And so in this case, I would be thinking of Prolo or PRP. And so I've had both. I've had tennis elbow and I've had golfer's elbow. I've done prolotherapy on my left tennis elbow that I had, and then I had golfer's elbow on my right, and I did PRP on it. And so let's take a look at that. Here you see me performing platelet-rich plasma or PRP on my left condyle. Okay, so as I was doing that, if you notice, I didn't have ultrasound on because, again, I didn't have an extra hand to be able to kind of use. But what I did do first was a lot of times what I'll do is I'll do a palpatory kind of experience first, kind of saying where is it kind of hurting, where's the ouchy spots, and I mark those up. Then I'll use my ultrasound. I'll look over those areas to see if I can confirm any pathology, but also make sure that we have a safe approach to be able to inject into those areas. And then I'll further use the ultrasound to search for any additional pathology of the structures, and then I will hit all those spots that are kind of bothersome. And so that's the typical approach that I'll do to be able to get it. When I treat things, I like to say I'm very full scope with what I do with sports medicine. So I treat from toes to nose, and I treat concussion too, so even further than that. But in the lower extremity, I treat lots of things like plantar fasciosis, knee arthritis, gluteal tendinopathy and tendonitis. When we go into the axial spine, treat a ton of sacroiliac kind of pain and dysfunction, a lot of back pain kind of things, whether it be, again, like chronic disc kind of issues or sciatica, low back pain and instability. When we look at the upper extremity, treating lots of rotator cuff and labral tears, notably in my former or current overhead athletes, a lot of tennis and golfer's elbow. And then also in the hand and wrist, lots of carpal tunnel, scapulonate instability, treating all those kind of things. So why don't many surgeons do this? And there are, it's like I just got done attending a conference where I was faculty, but it was kind of organized by, they like to refer to themselves as recovering orthopedic surgeons, because they're surgeons who kind of became woke in the sense of, you know what, surgery isn't always the best option. Maybe we should be looking at some other kind of things that we can be doing. And so again, why don't many surgeons do this? Well, I love this Upton Sinclair quote. So it's difficult to get a man to understand something when his salary depends upon his not understanding it. So let's talk about like the spine surgeon that's going to do a fusion. So this spine surgeon has the opportunity to make $110,000, as we were kind of discussing there, from that spine surgery. Or they can do a procedure that is going to take them out of the operating room, which they've spent a lot of their formidable years learning how to kind of master the art of the body, the spine, treating that in the operating room. They love being in the operating room. They don't love being in the office. And so we're talking about taking them out of the operating room, doing a procedure that takes a fraction of the time, a fraction of the effort, a fraction of the risk, and a fraction of the cost, an absolute fraction of the cost, and it could get them to the same endpoint or maybe even a better endpoint. And so why would a surgeon want to, do something where, again, there's a lot of benefits, but there's also a lot less benefit to themselves as far as monetarily. And so again, sometimes it's like ethically and morally, if a surgeon really embraced and learned about these kind of things, then they couldn't, with a good compass, kind of go in and say, okay, I'm going to do this surgery on somebody. And so a lot of them are just like, la, 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 I don't even want to hear about, I don't want to learn about this, just for that exact kind of factor. So if you're watching this and you're in the area, or if you want to travel and you want to schedule with us, we make it very easy to get in with our office. Again, lots of ways that you can kind of come in and see me. A lot of times if you're out of town, we do a telemed first. Our website is motionismedicinedfw.com. And then you can reach out to us at info@motionismedicinedfw.com. Follow us on social media. We post about procedures as well as other things. Our handle is @motionismed. And again, we're over in North Richland Hills, Texas, off of Davis Boulevard. Again, talking about all things, but notably the regenerative medicine that we were discussing here today. Special thanks to these physicians that lent me their slides and assistance as far as being able to help kind of refine my presentation that we gave you here today. And we just got back from Disney, and my youngest daughter, Scarlett, was not all in the mood for this photo. So I love this right over here. But if you do have any questions, feel free to write into me. And also feel free to go to my website, as we have some frequently asked questions on our website that talks about the regenerative medicine. So that being said, I really hope this recorded this time, because this is, again, round 3. I'm going to stop sharing it now, and I'm going to hit stop recording.